My name's Dr. Michael Jain. I'm at Moffitt Cancer Center in Tampa, Florida. And I'm here today to talk about an abstract I'll be presenting in a couple of hours, which is on the topic of what's called bridging therapy for patients who are undergoing CAR T-cell therapy, which is chimeric antigen receptor T-cell therapy for aggressive lymphomas. And so currently I'm a member of, and I'm presenting on behalf of, a 17-center academic consortium called the U.S. Lymphoma CAR T-cell Consortium. And this is a group of academics who have gotten together to study patients who are treated on standard of care CAR T-cell therapy for relapsed refractory lymphomas. And the reason this is important is that as academics, we can put together a large group of patients and follow them and answer questions that are relevant to try and optimize or make improvements to CAR T-cell therapy. I'll give a little bit of background. CAR T-cell therapy is a type of cellular therapy that is given to patients or approved for patients with lymphoma, particularly diffuse large B-cell lymphoma, that have relapsed after other types of therapies. And it's a very exciting outcome because it appears that around 40% of patients will get a durable long-term remission after this therapy. However, this therapy is sometimes associated with some toxicities, and really optimizing this therapy to make it as best we can is really important. So what happens with CAR T-cell therapy is that the first step is that we take out patients' T-cells and we ship them to a manufacturer. This requires a 3-week manufacturing period before we get the cells back and can go forward and treat the patient. The problem with aggressive diseases like lymphoma is that often during that 3-week period, patients may decline or get too sick to be able to receive therapy because of the aggressiveness of their cancer. So what our consortium asks, and what the abstract is talking about, is there anything we can do during that 3-week period to treat patients, what we call bridging therapy, to try and improve the number of patients that get to CAR T-cell therapy and improve long-term outcomes. So we studied almost 300 patients who had received this therapy, about half of whom had received some type of bridging therapy, whether that was chemotherapy, steroids, radiation, or a type of targeted therapy like lenalidomide or ibrutinib. And what we found is that for patients who were selected to receive this type of bridging therapy compared to ones who did not receive any therapy, those patients were at a lot higher risk. They were a lot sicker going into their therapy. And so we found that patients who received bridging therapy actually had worse outcomes after CAR T-cell therapy. Their overall survival was lower, and their progression-free survival was lower. And perhaps that's understandable given that there were sicker patients going into this therapy. However, we tried to use some statistical techniques called multivariable analysis or propensity matching to see if we could match patients who had not received bridging to patients who had received bridging to determine if still was there a negative impact of this bridging therapy on patients' long-term outcome after CAR T-cell therapy. And after multivariable analysis or propensity matching, we found that progression-free survival was not different between the two groups. However, overall survival was worse in the group of patients who received bridging therapy. And this overall survival, interestingly, was often impacted by patients having a poorer outcome when they relapsed after CAR T-cell therapy. They did not respond as well to subsequent therapies if they happened to be in the 60% of patients who did not respond initially to CAR T-cell therapy. So in conclusion, what this tells us is that it is not particularly optimal to give bridging therapy to every single patient. We think that we should carefully select the patients that really need the bridging therapy before we go forward with it for patients who are about to receive CAR T-cells.